Sinus tachyarrhythmia. Arrhythmia related to the sinus node. Arrhythmia related to the sinoatrial node can be classified as follows. A. Tachyarrhythmia. 1. Sinus tachycardia, ST, also called standard ST, or automatic ST. 2. Inappropriate, idiopathic, sinus tachycardia. 3. Sinus node reentrant tachycardia. And 4. Postural orthostatic tachycardia syndrome, POTS. B. Bradyarrhythmia. 1. Sinus bradycardia. 2. Inappropriate sinus bradycardia, chronotropic incompetence. 3. Sinus node arrest. 4. Sinoatrial block. 5. 6. Sinus syndrome. And 6. Persistent atrial standstill. Standard sinus tachycardia. Sinus tachycardia is defined as a sinus rate greater than 100 impulses per minute. However, sinus rates greater than 100 impulses per minute are normal in infants and children under 2 years of age. Occasional normal adults, as well, will have resting sinus rates slightly higher than 100 impulses per minute. Etiology of ST. 1. Physiologic sinus tachycardia, as in exercise or emotional stresses. 2. Pharmacologic sinus tachycardia, due to medications, such as sympathomimetics, parasympatholytics, vasodilators, exposure to alcohol, nicotine, or caffeine, or withdrawal from alcohol or drugs. 3. Pathologic non-cardiac systemic factors, for example, fever, hypoxemia, hypovolemia, hemorrhage, hypotension, anemia, thyrotoxicosis, pulmonary disease, or anxiety. 4. Specific cardiovascular abnormalities, such as heart failure, myocardial infarction, and pulmonary embolism. ECG in sinus tachycardia reveals a rate greater than 100 per minute, accompanied by a normal P-wave vector, and may reveal the etiology of tachycardia, such as evidence of myocardial infarction or pulmonary embolism. The upper heart rate limit in sinus tachycardia differs according to the etiology. In pharmacologic cases, up to 130 beats per minute. In fever, hypovolemia, hemorrhage, and hypotension, up to 140. In thyrotoxicosis and heart failure, up to 160. In physiologic cases, it can be up to 190 beats per minute. Rate variations in ST. In a persistent sinus tachycardia, the rate varies during the day, in contrast to the fixed rate in ectopic and reentrant tachycardias. The heart rate is an important differentiating factor between various forms of tachyarrhythmia. In sinus tachycardia, ST, the range is greater than 100 and up to 190 per minute. In paroxysmal supraventricular tachycardia, SVT, 140 to 240, including atrioventricular nodal reentrant tachycardia, atrioventricular reentrant tachycardia and atrial tachycardia. In atrial flutter, AFL, the atrial rate ranges from 200 to 400, while the ventricular rate is variable and may be regular or irregular according to the atrioventricular conduction. And in atrial fibrillation, AF, the atrial rate ranges from 400 to 600, while the ventricular rate is variable and irregular. Inappropriate, idiopathic, sinus tachycardia, IST. IST is a non-paroxysmal sinus tachyarrhythmia characterized by persistent increase in the resting sinus rate during awakening, unrelated to or out of proportion with the level of physical, emotional, pathological, or pharmacological stress, and/or exaggerated heart rate response to minimal exertion or a change in body posture. During sleep, the heart rate is usually normal. Diagnosis of IST requires presence of sinus rhythm greater than 100 beats per minute. P-wave axis identical to that during normal sinus rhythm. Exclusion of secondary causes of sinus tachycardia. Exclusion of atrial tachycardia. And symptoms clearly documented to be related to resting, or easily provoked, sinus tachycardia. Mechanism of IST. Inappropriate sinus tachycardia is thought to be due to enhanced automaticity of the sinus node. Autonomic dysfunction, due to autonomic neuritis or neuropathy, or impaired baroreflex sensitivity, with enhanced sympathetic or blunted parasympathetic tone, may be responsible. Idiopathic abnormality of the sinus node function with higher intrinsic heart rate is also suggested. Epidemiology of IST. Almost all patients afflicted with inappropriate sinus tachycardia are young women, especially those working in healthcare. Mean age, 38 years. Many of them are hypertensive. Symptoms of IST. The degree of disability can vary from asymptomatic patients, to chronic, incessant, and debilitating symptoms including palpitations, fatigue and exercise intolerance, lightheadedness, dizziness, presyncope, chest pain, and dyspnea. Can IST cause heart failure? Inappropriate sinus tachycardia is not expected to cause tachycardia-induced cardiomyopathy and heart failure, because the heart rate is normal during sleep, which gives enough rest for the heart. Some, however, believe that if fast enough and persistent for many months, it may precipitate a reversible form of tachycardia-induced heart failure. This is a 24-hour Holter recording, showing tachycardia during awake periods, and normal heart rate, less than 100 beats per minute, during sleep. Electrophysiological studies, EPS, in IST. EPS may be considered when other arrhythmias are suspected, or a decision to proceed with catheter ablation is undertaken. Invasive management of IST. Activation sequence mapping is needed, using a multipolar crista catheter, placed along the crista terminalis, in addition to the catheters used for a routine EPS. Intracardiac echocardiography may be used, to identify the crista terminalis, and guide mapping catheter positioning, as well as radiofrequency, RF, ablation. Left-sided figure shows the multipolar crista catheter. Right-sided figure shows the ablation sites during sinus node modification. Sinus node modification for IST. Targeted ablation of the sinus regions with the fastest rates is done, while maintaining some degree of sinus node function. It is rarely required, and results are not encouraging. The success of the procedure can be detected during ablation, from the sequence of activation in the crista catheter channels. This is an intracardiac recording from the multipolar crista catheter before ablation. A waves appear first in distal crista catheter channels, high up near the upper part of sinus node, which has the fastest firing rate. This is an intracardiac recording from the multipolar crista catheter during ablation. A waves appear first in mid-crista catheter channels. This is an intracardiac recording from the multipolar crista catheter after ablation. A waves appear first in proximal crista catheter channels, low down near the lower part of sinus node, which has the slowest firing rate. Complications of sinus node modification. Cardiac tamponade, rare. Superior vena cava syndrome, transient or permanent, due to extensive lesion creation and edema. Phrenic nerve damage with diaphragmatic paralysis. Sinus node dysfunction. Sinus node reentrant tachycardia. Reentry occurs within or adjacent to the sinus node. It accounts for 5 to 10% of cases of supraventricular tachycardias. It is most frequently seen with structural heart disease, especially inferior myocardial infarction. Rate, 100 to 190 beats per minute. Being a reentrant arrhythmia, it has an abrupt onset and termination, paroxysmal, and can be induced and terminated by stimulation. It may be difficult to distinguish, clinically and by ECG, from the standard sinus tachycardia, except for its paroxysmal onset and offset since the P-wave morphology is similar. Postural orthostatic tachycardia syndrome, POTS. This syndrome is also called chronic orthostatic intolerance. Diagnosis requires an increase in heart rate more than 30 beats per minute from baseline, or to reach greater than 120 beats per minute, within 10 minutes from upright position, without postural hypotension, or any other demonstrable autonomic neuropathy. Symptoms may include palpitation, tremors, and presyncope, and the syndrome is commonly confused with other chronic syndromes, such as the chronic fatigue syndrome, and inappropriate sinus tachycardia. Mechanism of POTS. Two forms are described. 1. Central beta-adrenergic receptor hypersensitivity, due to failure of synaptic clearance of norepinephrine, with exaggerated sympathetic response to physiological stimuli. 2. Peripheral dysautonomia, due to mild idiopathic peripheral autonomic neuropathy. Thank you.